So we finished yesterday at placental abruption. So one of the important topic that I don't want to miss is vesa previa. So vesa previa is one of the very, very important topic, and a lot of questions or MCQs come from this topic as well, because people neglect this topic and think it's not that important. So you need to make concepts. When I said remember by heart, it means you have to remember some things, like, since you have to make concepts, but at the same time you need to make you need to remember the things to solve some MCQs. Then starting from the vesa previa, what is vesa previa? So here in this picture, what happened here is, this is cervical os, this is fetal vessels, and this is umbilical cord. So all this placenta is here, but all the vessels comes in front of the cervical os. So with the name of it, vesa previa, vessels in front. So it comes in front of the cervical os. That's why the spotting started. So what happened? An unprotected blood vessels, fetal vessels, pass over the cervical os associated with a filamentous insertion of the cord into the membrane of the placenta or the accessory lobe. So epidemiology is basically higher in the twin pregnancy. So if you get to know that this is coming in a twin pregnancy, and that in particular scenario is giving you an option that this is twin pregnancy, so you will easily tell that this is vesa previa. Now, what is clinical features? Clinical features is basically painless bleeding. So now you have to differentiate, is either it is vesa previa or is it placenta previa, because both come as painless vaginal bleeding. And then fetal distress. So in that placenta previa, more of the mother having problems, but in this vesa previa, more of the fetus having problems. So maybe tachycardia or bradycardia in the sinusoidal pattern. If undiagnosed, what happened is 50% of the perinatal mortality, maybe baby died in that, a lot of spotting was happening and mother was neglecting it. So what happened is prenatal mortality increasing to 75% if the membrane rupture. If diagnosed antenatally on ultrasound, without labor or symptoms, then 97% survival. All you need to do is counseling, and counseling we already read in that up in that here this part. Limited physical activity, no douches, enema, and then sexual intercourse. So you can apply anywhere when a female is coming with the bleeding. So you have to remember them. So you can write, if they give you 1, 2, 3, 4, 5 lines, so you can write physical activity, no douches, enema, and sexual intercourse. So you can write in placenta previa, placental abruption, and vesa previa if you are counseling. Then comes the investigation. What are the investigations you need to do? 2 investigations. APT test, which is basically NaOH mixed with the blood. And then if it is pink, then it's basically coming from the fetus. And if it's yellow, then it's the blood is coming from the maternal. So on the basis of APT test, you can do it. The blood is coming from the fetus or maternal. Then another test is right test on the blood smear, and look for the nucleated red blood cells in cord, not maternal blood. Then is basically what happened is vesa previa, you do planned cesarean delivery. Okay, here I want to mention 2 things. In placenta previa and in vesa previa, we do cesarean delivery. But in placental abruption, even it is painful and stuff like that, but we can still do vaginal delivery. Here, vaginal delivery otherwise contraindicated. If vaginal delivery we cannot do, then we go for cesarean delivery. But in placenta previa and in vesa previa, we go for cesarean delivery to be on the safe side. Until the woman wants, no, I don't want to cesarean delivery and stuff like that, then we consider her, tell her about this sign and symptoms, about all the complications, then we go for it. Okay, then is the next topic. I'm not sure what I told you. Okay, so the next topic is basically intrauterine growth restriction. This is important. These ones preterm labor, but it is all about cervical cerclage and progesterone. So you need to know when you can do cervical cerclage, when you need to do progesterone, at which phase. Like, because cervical cerclage you do at T2, like at the end of the T1 or in the T2, and removed in T3. But what happens in progesterone, it is like exactly like the giving some progesterone pills or any injection whatsoever is like easy for that particular woman. So you can give it any time of diagnosis. So if she's coming with a T1 at T2, T3, anytime she wants it, you can give progesterone. And when you diagnose this is short cervix and we need to preserve the pregnancy and she doesn't want to go for cervical cerclage, and progesterone. Then comes the lifestyle modification and predicting preterm labor. So there is a question that I saw in ASQ Bank, and it was asking about this, that a fibronectin test comes out positive. What are we going to do? Expectations. So the expectations, because this negative NPV is more than positive, so that's why we don't consider it as a accurate test. So we still do it, but this is negative predictive value is more than positive. So that's why we don't take it like in a definitive or diagnostic test. Then how do you manage it? So you have to remember this. That's why you need to know what comes first, transfer, right? So a lot of questions that come in the clinic, what you do is transfer to the ER. Then comes is what you are going to do is tocolysis. Then you give steroid, because the tocolysis, why we are doing tocolysis first? To preserve some time, then give steroids, so that steroids can work, and the tocolysis is particularly done so that particular female can be transferred from that clinic to ER, or that particular place to some other place where she needs to be there. And that steroid, when you are giving, it can have enough time to work on that female or in that neonate. So that's why we need to give tocolysis. But in sometimes we don't give tocolysis. There are some contraindications that is mentioned here, that bleeding, disease, eclampsia, chorionitis. So in those particular conditions, we don't give tocolysis. So you need to know this contraindication. Sometimes they give you that woman is coming with a bleeding. What are you going to do? So you are not going to give tocolysis. Are you going to preserve it? No, that's not the right answer right now. What are you going to do next is maybe you can give something else. And then you need to know what is tocolysis agents, calcium, which is nifedipine, and prostaglandin. Let's suppose both are mentioned in one MCQs. What I'm going to choose? For me, I will choose prostaglandin, because prostaglandin is very easy, less side effects than the nifedipine. Why nifedipine? Why not nifedipine? Because nifedipine has like effect on heart. So there is a lot of contraindications of the nifedipine as compared to prostaglandin. So that's why I said you need to know the contraindications. So on the basis of that, if both of the things are mentioned, so you need to know which is easy and which you can do it like without any problem. So you need to, other than that, because you want to treat the patient and to keep the patient safe as well. Antenatal corticosteroids. Antenatal corticosteroids is betamethasone. And when should be the betamethasone given? Betamethasone should be given at 24 to 36. 24 to 34 plus 6. 6 means like less than 35 weeks. So you have to give it before 35 weeks, right? So it is very important that you know it should be given before 35 weeks, and it should be delivered. And when you already give corticosteroid, then the baby should be delivered in 7 days. Neuroprotection MGSO4 should be less than 33 plus 6. So it is very important that you need to know the when is corticosteroid should be given and when is neuroprotection should be given. There is only 1 week difference. So that's why
first-line treatment for trichomoniasis is with oral metronidazole or tinidazole.
Okay, so you guys cannot hear me? You guys cannot hear me? Anybody can tell me?
No, we can hear you.
Okay.
Yeah.
So antenatal corticosteroid is basically given at less than 35 week, and then neuroprotection should be given less than 34 week. So it is very important you know these weeks, because if somebody come present with more than that particular week, you cannot give that neuroprotection or you cannot give that corticosteroid. But at the same time, you need to know what are neuroprotection, MGSO, SO4, 4-gram bolus. It should be given. It should be given less than 34. This is important. Okay. These ones are important. These ones, what I'm highlighting here. Okay. Then the prognosis, sometimes, here and there, you need to know the prognosis as well. Then the prematurity increases newborn risk factors. This is important because sometimes prematurity comes and other than that, there is nothing else mentioned. So you know these things, it will be easy for you to solve MCQs. And why I'm saying remember them by heart, when you know these questions, you solve them, you save time for some other things. You might need to put your concept in some MCQs where you need a lot of time. So if you save some time from some MCQs, you can put it over there. like eventually how you solve questions in your particular exam. So you save some time from one MCQs and put the time into the different MCQs. Then pre-labor rupture of membrane. There are three of them: pre-labor rupture of membrane, then prolonged rupture of membrane, and preterm pre-labor rupture of membrane. So these are three are important. So you need to know the difference. What is this, and what is this one? And then risk factors are the same for all of them. Then the clinical features, investigation you need to do, nitrazine test is done, Ferning is used, and then ultrasound. These are the three things you find out when the membranous status determined. If you know these things, either one of them will be mentioned in the MCQs or scenario. So you get to know, yeah, this is preterm labor rupture of membrane. Then on the basis of that, investigation is same for all of them. But on the basis of the gestational age, the management is different. In 22 to 25, what you do is only counsel and see, like wait and watch and observe and ask her, like, this could happen, this could happen. So you are what you are doing is counseling, telling her about the risk factors, it's what she can do to preserve it and stuff like that. But in 26 to 34 week, what is that? Expected management. Maybe she come with a very high features, so you have to, all you need to do maybe giving corticosteroids and do the delivery. But if she's coming with a little bit lower stage, all you can do is counsel her, ask her to come again, or maybe you can admit her, let her rest and stuff like that. But in 34 to 36 week, this is basically gray zone. What happened here is RDS is common. So RDS or sepsis can present. So you can give corticosteroids to present for RDS, and sepsis you can give antibiotics. So, so which antibiotics can be given? It should be written on the side here. Erythromycin, mostly ampicillin is given. Ampicillin or amoxicillin. Ampicillin is given in IV and amoxicillin is given per oral. So, but not clavulanic acid or not those things which is basically erythromycin or any doxycycline, because those can cause teratogenic effect, and those are not given in those. So then comes next is basically in more than 37, all you do is basically keeping the baby inside the belly is more dangerous than delivery. So that's why we would deliver the baby. Induction of the labor increase the risk of death from the sepsis is greater than RDS. So you have to see what is safe for the baby and go for this. So in the if there is a prolonged rupture of membrane, if there is a scenario that they're giving that this is a prolonged rupture of membrane, 24 hours happen, and they ask in a scenario, what is the option you have to choose is given antibiotics is very important, because you have to save the baby from the sepsis. But if the same baby is coming in to 34 to 36 weeks and they are giving antibiotics, in the scenario they have given antibiotics and corticosteroid, what I'm going to choose is basically corticosteroid, because I have to preserve the baby from RDS. Okay, so prognosis is important as well. You can read it. Post-term delivery. So what happened is basically macrosomia. So if you know macrosomia, post-term delivery would be easy for you. Then comes intrauterine fetal death. One of the like very, I would say, questions might be asked from this one, but it is asked in mostly in MCQs. So you need to know about you need to know the concept of it. What could be the causes that causes the fetal death? Because sometimes what happens is like spontaneous abortion. Some people mix it with the abortion. So you need to know before 20 week, it's abortion. But after 20 week, it is basically death, fetal death. And woman is the mother is not liable for fetal death until the baby comes out of the female and had their individual like body outside in this world. They don't carry any lethal like any basically any rights. So that's why if a female carrying a baby and the baby died, then that particular female is not liable for that death. Okay, so this is the one of the question of the ethics, and very much asked here and there. So in CMPA, it is very good topic written over there, so you can read it from there. Then clinical features is basically what happened is obviously mother start focusing that my baby is not moving and she coming to you, and then what's the next step you will do? You will check for the symphysis. If a mother is coming to you and she said, I didn't find the movement, what are you going to do? You are not going to label it that this is a fetal death. What are you going to do next is you're going to check for the symphysis fundal height. If you already checked it and it's not increasing, what are you going to do next? Next is basically you have to check for the ultrasound, right? Those things are done. Then on the basis of that, you said that this is fetal death. Just because she couldn't do fetal movement and height, symphysis height is not growing, it doesn't mean that baby is dead. Maybe baby is sleeping, maybe the baby is not moving, maybe the baby growth restricted. So you still have to do ultrasound to confirm that the fetal died. Then you can label it, yes, the fetal is dead. Now we have to do is delivery. And all you do is the management is basically, I said cardiac activity, fetal movement on ultrasound. All you do is cesarean delivery because now fetal is dead. Now here, treatment. This is something I would say, remember word to word. Like more than 10, what you do is induction of labor, monitor for the maternal coagulopathy, parental psychological care, bereavement support as per hospital protocol. So you have to, I feel baby died, all you need to do is obviously deliver the baby, give the baby to the mother, let her spend some last moments with the baby, then do the bereavement counseling support because baby mother is in grief, so she needs psychological support. So you have to give social support to her. And then what next you have to do is 3 months after you have to discuss about the final investigation because you did the postmortem, and then you have to find out what could be the cause and discuss with her, maybe genetic features, maybe so on the basis of that you can counsel her about the upcoming pregnancies, in the future pregnancies. Because if you don't discuss about these features and this happened again, so you will be liable for that. So you have to do is basically all you have to do is counsel the mother about the future pregnancies. Then comes the intrauterine growth restriction. This is important. So estimated fetal weight less than 10 percentile for the gestational age, or the ultrasound has not been reached biological determined growth factors. So this, and I think there was once one topic in peds, when that we will discuss, I will tell you this and that one, you need to know the difference between it. I'm not sure what the topic name is, so I will not say any name here. So the risk factor most of the time is 50%. Maternal causes is malnutrition, smoking, drug misuse, alcoholism. So you need to remember what are those causes, and maybe what is the placental causes, what is the fetus causes. So most of the fetus causes basically infection, some infection going on, or maybe congenital. Now, clinical features, it comes in two ways, either symmetrical and either asymmetrical. What is symmetrical and what is asymmetrical? Symmetrical means that the upper part of the body and the lower part of the body is in same growth phase. If that is not growing, that the head is not growing, it doesn't mean at the same time the lower part of the body is not growing as well. But in asymmetrical, what happens is if the head is growing, but the lower part of the body is not growing. So one of the two are not growing, right? So this is important. You need to know what is the difference between them. So now symmetrical and asymmetrical, how will you differentiate? Symmetrical presents in early stages. If they are saying, let's suppose if they tell you that the head and abdomen both are reduced and everything, and she comes in like 37 phase. If she comes in 37 phase and then both of them are reduced and everything, you will get an idea that it started in early pregnancy, which was unnoted for a long time. And now she's presenting and she is having this symmetrical, right? Because, and then is mostly associated with the congenital, because a lot of body organs are forming in the early phase of the pregnancy. So which one is more dangerous? What do you guys think? Symmetrical or asymmetrical? Obviously symmetrical, because symmetrical is causing the congenital anomalies. But asymmetrical is basically like one part of the body might be hydrocephalus is happening, might be belly has a lot of water, or maybe these kind of, but when she came out of the obviously when she came out of that belly, you can still treat her, try to fix it up, so you could do something about it. So fetal abdomen is disproportionate, smaller than the fetal head, brain is spared. Since brain is spared, that's why it's saved. Here the brain is not saved, so that's why it is not safe. Do you get my idea? This is important. You know which one is dangerous and which one is not dangerous. Therefore, head and abdomen is increased and associated with a placental insufficiency. Most of the time, what happens is placental insufficiency. Some part is, collapsed and not giving enough blood or nutrition to the baby. That's why it's not growing up. Then comes the complication. What would be the complication? Maybe aspiration, asphyxia, polycythemia, hypoglycemia, hypocalcemia, everything is going down. Hypo. So even intellectual disability is going down. only polycythemia, because he or she, the baby, is not fully breathing. That's why what happened is the RBCs start forming, so to overcome that hypoxia, that whole mechanism. That's why polycythemia is happening. Then all the torch infection which is happening in the asymmetrical here, torch infection. So this is torch infection: toxoplasmosis, syphilis, rubella, cytomegalovirus, and others. Then investigation, obviously starting from the symphysis fundal height. Why we are going to do symphysis fundal height? We need to find the measurement of the head and abdomen. So because this is least invasive procedure. Always remember, when you are going to start with the investigation, always start with the least invasive, where the baby is safe, mother is safe, no radiations, nothing is going on, and you can do it from outside. Because here in Canada, all we need to do is save the government funding, save all those extra procedures which is not needed, save everything which can cause a problem for the patient. So you have to start from the non-invasive ones, or maybe start from the lower ones. So what is the first come? Symphysis fundal height. If the mother at the lower risk of symphysis fundal height lags more than 2 centimeters, then we switch on to ultrasound, then we switch on to BPP, then we switch on to Doppler analysis, whichever is needed, right? So we can do on the basis of that. If she has this, we will do this. If she has this, we will do this. That's what's important is. That's what I'm saying. You need to know why, how, whatever you're studying, make sure you know the concepts of it. That if I am studying this, what is the point of this? If this is the answer, why is this the answer? Okay. Then comes the management. What is the management? Obviously prevention. So in the, like, if the baby can be saved and all of these things, like risk modification. If the mother is not eating properly, you have to tell the mother to eat properly. If she's smoking, counsel about smoke. If she's drinking alcohol, counsel about alcohol. So all those modifiable controllable factors, like here, these ones. So first comes first, all about the counseling. Then moving on to the next one is basically CLBPP, delivery when extrauterine existence is less dangerous than the continued intrauterine existence. If more than 34-week gestational age, optimize fetus with a celestone. Celestone is basically corticosteroid. And then giving magnesium sulfate for the neuroprotection, early GBS swab, and then pediatrics consult, because if the baby is going to be delivered and it's small, what we need is pediatric to come and check the baby if he is okay, or he needs further treatment. And IUGR fetuses are less likely to withstand stress of the labor. So that's why we do cesarean delivery. But it's not high likely that we will do cesarean delivery, because baby cannot withstand the stress. That's why we're going to do cesarean delivery. Then comes the macrosomia. Macrosomia is more than like 90th percentile of the particular gestational age, more than 4 grams. So risk factors basically obesity, diabetes mellitus, macrosomia infant, and prolonged gestational multiparity, and the gain during the pregnancy. Maybe mother is gaining a lot of weight. One of the very, very risk factors is basically diabetes mellitus. Diabetes mellitus, mother has macrosomia. So increased risk of prenatal mortality, CPD, birth defects like shoulder dystocia, fetal bone fracture. So these can be because baby is a lot bigger than the CPD. So that's why when the baby is passing out, so might break the shoulder dystocia, head, pinned, and everything. So investigation. So obviously in the what we were doing in the intrauterine growth restriction, symphysis fundal height. Same goes in the macrosomia. What are we going to do first is symphysis fundal height. Non-invasive first, then we move on to the ultrasound. Then what comes the management? Management is basically prevent hyperglycemia in the patients with the diabetes mellitus, optimize pre-pregnancy weight, and limit excessive pregnancy weight gain in the patient with. So you have to counsel her, please reduce your diabetes. If you have diabetes, take proper medications. And what are the good medications? We start with the insulin, and obviously we can start with the metformin, but metformin is not approved one. So we start with the insulin and what weight gain. So she can control about the diet. We can control about exercise. So don't gain too much weight, which is dangerous for the baby. And plant CD is a reasonable option where the weight is more than 5. What are we going to do is CD. But if it's more than 45, we can still counsel her, and then we can ask her if she's diabetic with 45 grams, what are 4,500 grams or 40.5 kg. What are we going to do is we are going to ask for the CD or counsel about the CD. Remember, we are not going to do CD. we are going to give the option of CD. That's why I'm saying when you are writing CDM questions, always remember which words you are picking or which words you are writing. It is very important that you don't write, I'm going to do this, because you cannot do this until the patient is willing to do that. Then comes the polyhydraminos and oligohydraminos etiology. So polyhydraminos is more than 25 centimeter and oligo is less than 5 centimeter. We do ultrasound if more than 8 centimeter and this less than 2 centimeter. So if you do with the comparison, it will be easy for you to remember all the etiology. What happened here is basically flow is disturbed, fetal hydrops, a lot of fluid is collected. So what happened in the baby, what happened in the maternal fetal etiology, multiple gestation, chorioangiomas, fetal hydrops. Fetal hydrops, where I told you 2 compartments have fluid, then it's called fetal hydrops. Fetal, what happened is chromosomal anomalies in the Down syndrome, polyhydramnios, respiration, CNS encephaly, hydrocephalus, meningocele, tracheophasic fistula, duodenal atresia, and facial clefts and problem with the swelling. In oligohydramnios, the most common is basically when the baby is having a problem with the kidney. So most common is this one, but other one is basically idiopathic, is basically most common. Maternal uteroplacental insufficiency, or maybe medications, congenital urinary tract infection, obstruction, posterior urethral valves, hypoxemia, IUGR, and prolonged amniotic fluid leak. So that's why the fluid is leaking for so long. Amniotic fluid normal decreases after 35. So after 35, if she is coming and then amniotic fluid is low, then it is normal. Okay. Then comes the clinical features. What happened in the polyhydramnios, and then what happened in the oligo. Oligo, obviously, the too less fluid, so baby is not easily movable. So baby is restricted. Baby is not growing properly. Baby's facial features is disturbed. Baby's limbs is disturbed. Maybe baby has amphalocele. Baby has gastroschiasis. So all the abdominal wall defects and cord compression. Fetal outcomes, hypoplasia. So one of the things that are not mentioned here, I would say you need to know oligohydramnios, which genetic defect it is common in, and polyhydramnios, which genetic defect is common in. So I don't know if it's not mentioned here. I don't think so. So you can read it from the medical genetic chapter. It is written over there which one is common in which one. So then in this one, there is a lot of fluid. So what happened is that edema, dyspnea, hydronephrosis, cord prolapse, placental abruption, malpresentation, preterm labor, uterine dysfunction, and postpartum hemorrhage. Management, what are we going to do is according to the cause. If there is a lot of the fluid present, first, we are not going to do. First, we are going to check maybe there is an underlying pathology going on. So we have to nip the bud from the evil. So we are going to do is take out the cause, find out the cause and treat that one. Screen for the maternal disease and infection, then fetal ultrasound evaluation. What are we going to do next is depend on the severity. If there is too much fluid, what are we going to do is we are going to do amniocentesis, take out some of the fluid. But in here, in this one, oligohydramnios, there is less fluid. What are we going to do is we are going to rule out rupture of membrane if there is any leakage of the fluid going on. Then fetal monitoring like NST, BPP. So we have to rule out maybe baby is having any problem. So we have to see all the investigations, all the admission, ultrasound, Doppler, if the baby is having enough fluid, if the baby is having enough nutrition, if the mother is eating properly, if there is anything underlying pathology going on the basis of that. Maybe mother is dehydrated, maybe mother doesn't have enough fluid. So increase hydration, amniotic fluid. If she is still not getting well, so what are we going to do is put the amniotic fluid into that particular placenta. So injection of the fluid via amniocentesis with the improved condition in 1 week. So consider delivery if everything is not working. So amnio infusion may be considered during labor. Maybe that placenta stick with the baby. So we need to put fluid to get it detached from that. So prognosis, 2 to 5-fold increase in the risk of perinatal mortality and proved with the early onset higher mortality and related to the congenital malformation and the pulmonary hypoplasia. So it is more common with the congenital malformation because I already told you there is enough fluid, not enough fluid. So baby is not easily moving. So that baby is restricted. Okay. So I think that's it for today. What else are the topics left? Hypertension and diabetes. Those are very important and I don't want to make it super fast. We need to make up little concepts about that. So in the next session, we'll try to cover up this one and we'll start with the next topic, right? So anybody has any question in regards of that?